I
First, you
think
want to take
probably,
over and introduce Gordy?
yeah, but Charlie, before I do that, let me ask you if you want to give us an update on our reunion. Uh, you know, sketchy as they are, do you want to kind of bring us up to date on that?
Yeah, the executive committee met earlier this month, and we had Stephanie Hartnett, who is our YAA support person, working with us, and she reported to us that our 73 union will be held in the fall of 2026. Class of 54 just had theirs this fall, and 55 is planning theirs for this coming fall. And there are good reasons for doing it there. Number one, we can get hotel rooms easier. We can have our own program. And those are two of the main reasons that we would be doing it in the fall instead of in the spring. We don't have a date yet. We did talk about whether we should do it with a football game or weekend or not. And Tersh and we've got Tersh and Mark Burnbloom and Ray Foote, who gonna kind of put together a proposed agenda and talk to us a little later. We've got to, a little more than a year and a half to get this worked out using the YAA support. Tersh, you want to add anything to that?
Yeah, I think the most important thing is that we need some vitamin pills in order to get through that next year and a half.
Exactly.
But it's great to see everybody. Before we start, I would just like to have the people who haven't been on the line very much to introduce themselves. I see Peter Breyer somewhat in the dark, which I hope he isn't. But Peter, can you put a light on your face? Yeah. And Mike Nassau, we haven't seen very much of. It's good to have you, and Ellie Southworth, and I guess that's about it. Okay, let me start by saying, as Charlie sent out, we had, quote, technical difficulties the last two sessions, so we didn't have a October or November speaker, and that left us with a December speaker. So we're so glad that Jordy has remembered or has figured out how to get his ducks in a row. And
Thanks.
we're just delighted to see you. Let me just give you a brief introduction. Jordy served as president and chief executive officer of the Association of American Medical Colleges, the AAMC, and you'd have to add a TH, and teaching hospitals. So Association of American Medical Colleges and Teaching Hospitals from 1994 to 2006, which is pretty darn over 20 years. And the AAMC is the policy spokesman really for the nation's doctors. So it's important that Jordy was in Washington and in the negotiations on the Obamacare. Prior to his leadership of the AAMC, he served as dean of the medical school of the State University of New York, and that's in Stony Brook on Long Island, and as president of the medical staff at University Hospital. Jordy, where is the University Hospital?
It's Stony Brook.
At Stony Brook, okay. And he has served at several other medical positions and has been on numerous health and medical organizations. But for this broadcast, the most important thing is that he and Peter Braun at the bottom of the screen have been officially designated as our class doctors, keeping us healthy, speaking at reunions, and we really appreciate that. Okay. In 1965, under the leadership of President Johnson, Congress enacted the Medicare and Medicaid under Title 18 of the Social Security Act to provide health insurance to people 65 and older.
Sure, you're giving my talk.
What? Regardless of the person's income or previous medical history. The ACA is the landmark federal statute enacted and signed by President Barack Obama at the time in March of 2010. And together with the amendments to the Reconciliation Act of 2010 represents the U.S. healthcare system's most significant regulatory overhaul and expansion of coverage. And we have a note here that says most of the Act's provisions are still in effect. No thanks to our GOP brethren. Jordan's talk should be very interesting, particularly in light of the political environment. We has been tried to be repealed, I think, 60 times, if I'm not correct, during the Trump administration, none of which were successful. So we are ready to go. And Jordy, thank you so much for your third try. And I guess it's like strikes and
Hope it works.
3 strikes, you get 3 strikes, and you're on.
Thanks, Torch, for the introduction. Been looking forward to this talk for some time, so I hope it. I should let everybody know I just got back last night from a 2-week trip to Taiwan and Vietnam, so I may be a little bleary, but I'll try to be coherent. So I've entitled this "A Stroll Through Time: My Own Take on Medicine's Past and Future." Let me start with a brief quiz. What was the life expectancy for a male born when we were in 1934?
71.
Shout out. How many?
71.
71. Any other thoughts?
Less.
I think so.
Well, here's the surprising answer. 59.
Oh my.
Based on the mortality conditions in 1934, we all were expected, on average, to live only 59 years. So, among other things, we can count our lucky stars for having way outlived what we were expecting. So, here's what's happened since then. In the last, 70 years or so, a male born today would be expected to live almost 20 years longer than our expectation was. Now, most people would assume that this is due largely to healthcare, to help the advances in healthcare. And in fact, that's true. But I want to point out that there's a lot of very important non-medical reasons for the increased longevity, not the least of which, in fact, a very important part of it, is decreased infant mortality, particularly in immature premature births. But sanitation, clean water, decline in smoking, reductions in poverty, all had major impacts on increasing the life expectancy during our lifetime. But medical advances have certainly been a part of it. And I just put together an incomplete but a rather impressive list of medical advances that have occurred since we graduated. Novel imaging techniques, ultrasound, CAT scans, MRI, PET scans, new surgical techniques, minimally invasive laparoscopic surgery, coronary angioplasty, organ transplantation, robotic artificial joint implants. I have 3 artificial joints. Among us, I'm sure we have over a dozen knees or hips or shoulders. In vitro fertilization, genetic testing, gene therapy, breakthrough medicines, including oral contraceptives, Viagra. I don't know how many of you benefited from that, but I certainly did. Mood-altering drugs, Valium, Prozac, statins for treating high cholesterol, effective antihypertensive, more very effective antibiotics. Penicillin was the only thing available at the time that we graduated. AZT for treat AIDS, and the new GLP-1 receptor agonist, Ozempic being a prototype, are going to be fantastic improvements in health. Acute and chronic dialysis, life-saving vaccines for measles, mumps, scarlet fever, hepatitis, chickenpox, and COVID-19. Not a single one of these advances existed at the time we graduated. Now just think about that for a moment. Look what's happened in our lifetime in the way of medical advances. So it's truly been astonishing. So it's certainly impacted life expectancy, but it's also added enormously to the quality of life. But it has had a cost, an inexorable rise in healthcare costs as a result of all of these marvelous advances. In 1956, when we graduated, 2.7% of the GDP was due to healthcare costs. 2.7%. Now it is over 18%. It's an incredible rise in healthcare costs, which everybody is well aware of. But I think putting it in its historic perspective, I think, is a pretty dramatic illustration of what's happened in our lifetime. Well, as a corollary of that, in 1956, only 70% of our population had any kind of health insurance, and most of that was just for hospital care. There was nothing for doctor's visits or for medications or anything like that. It was limited to hospital care. Well, that is, as Tersh has already mentioned, in 1965, as part of Johnson's war on poverty, Medicare and Medicaid were part of that major advance in legislation, and that produced a tremendous interest. The impact of Medicare, of course, was to increase access to health care for older adults, but the major political argument in favor of Medicare at the time was an attempt to reduce elderly poverty, which was an embarrassment that was very politically very important to get to address. But the indirect impact of Medicare, I think, has been even more impressive. First of all, it has been largely responsible for the growth and modernization of our healthcare system. It's put enormous cost pressures on the healthcare system, and it's also been a catalyst for much broader healthcare reforms, including an increase in private insurance. And that's what happened after Medicare was enacted. You can see there's been a dramatic increase in the percentage of our population that was covered by health insurance. But along around in the late 80s, it began to slacken off, and people became even more concerned about the uninsured segment of our population, which had a lot of both political as well as adverse health consequences. Well, Clinton tried to address this issue, and this is where I first entered the picture, as first mentioned. In 1994, I moved to Washington to become president of the AAMC, and we had a very active role in trying to influence the Clinton's healthcare and Hillary's healthcare reforms. You may remember Ira Magaziner, which I'm happy to say was a Brown graduate, not a Yale, was largely responsible for putting together this enormously complicated, very arcane set of proposals, which just the mere weight of it was enough to cause its demise. So as you know, it failed to pass Congress largely because it was so complicated and hard to understand. But there was an enormous pushback by the health insurance industry to try to prevent the passage of this healthcare reform, which would have done a lot of financial damage to the healthcare industry. So in any event, nothing happened until Obama came along, and in 2010, finally, we had something that was closely allied to universal coverage. The Accountable Care Act, or Obamacare as it's often called, had a dramatic effect on the amount of uninsured, reducing the uninsured population to less than 10% of the population. There was still over 20 million people who lacked health insurance even today as a result of the impact of the ACA, but it had a dramatic impact on the amount of coverage that exists. It also had some impact on the cost. One could extrapolate that without the ACA, if one just continued on the pace that we were on, we would have received over 18% of the GDP due to healthcare costs about a decade earlier than in fact occurred. So there was some improvement in the advance in healthcare expenditures, but clearly still a major problem. So what were the major features of the Accountable Care Act? Well, one that's not often recognized, but which is a huge change, was Medicaid expansion. The bill, as it was initially passed, it required all 50 states to adopt Medicaid expansion as part of the program, but the Supreme Court quickly decided that that was not constitutional, and it was the states that had to agree to have their Medicaid programs expanded. And so only so far, only uh, uh, 10 states have not adopted Medicaid expansion. As you can see, it's largely the red southern states, as well as Kansas, Wyoming, and Wisconsin, surprisingly, although Wisconsin seems to be on the verge of now accepting Medicaid expansion. But this has been a major limitation to what otherwise would have been a more comprehensive impact of the ACA. In any event, Medicaid expansion in the 40 of the 50 states that did expand it greatly increased the number of insured. Over 20 million additional people have been insured, and had all 50 states accepted Medicaid expansion, another 3.5 million people would have been covered by health insurance. So what the Medicaid expansion did was to allow any adult less than 130% of the poverty level would be covered. Children in low-income families were covered, and pregnant women up to 185% of the federal poverty level were covered by Medicaid. In addition, there was support for safety net hospitals, largely in rural and inner city locations, but this was a major boon to those hospitals which had always struggled and still do struggle financially. But an important advance. Long-term care was included in Medicaid expansion. Long-term care is not available in Medicare, as you probably know, except for a very limited number. But most of the long-term care is paid for by Medicaid or by private insurance. Positive economic impact has been most impressive. The reason is that the US government, as you probably know, covers 90% of the costs for all of the eligible individuals. So the states get an enormous economic benefit from expanding their Medicaid program. And it's been just a source of some puzzlement as to why 10 states have still chosen not to take advantage of this economic boon. Well, in addition to the ACA, also another major impact was the establishment of health insurance marketplaces. This is an easily available internet service that is available, that all eligible health insurance programs can put their products and their costs and all the information that they want to communicate on this website, and people are free to choose among various approved health insurance plans. In addition, there is a considerable subsidies and premium tax credits for individuals and families up to 400% of the federal poverty level. Any employer that employs over 50 individuals is mandated to offer a qualified health insurance plan, at least one health insurance plan for their employees, dependent coverage for all eligible beneficiaries until dependents until the age of 26. A major change was the banning of any denial for pre-existing conditions. This had been a major shortcoming of the health insurance programs before Obamacare, but since then, no pre-existing condition could be used as an excuse for denying coverage to an individual. There's no annual or lifetime coverage limits that are allowed, which had been frequently part of the health insurance products before that. The plans must cover 10 essential health benefits: maternity care, mental health services, prescription drugs, emergency service, laboratory services. All qualified plans must include these benefits. In addition, free preventive services, routine vaccinations, and various screening services must be included in eligible plans. And there was a labor mobility was promoted by the fact that health insurance now had to be made available by all employees who had as many as 50 employees. This reduced what was called job block. If you had, prior to the Obamacare, if you had a job that provided health insurance and wanted to leave that job to get another position, you took the risk of losing your health care coverage if your new employer didn't offer it. So that was another benefit for the program. Well, the result was that about half of the improvement in the uninsured population was due to Medicaid expansion, and the other half was attributable to the marketplace enrollments. So there was over 20 million additional people were insured as a result of Obamacare. Well, it didn't come cheap. It's now estimated that between 120 and 150 billion dollars annually are required to implement the ACA, which of course this is the major criticism that the Republicans have of Obamacare and why they are at least rhetorically interested in seeing it eliminated. But the fact is that it's become enormously popular. You can see back when it was started, less than half of the people in the country who were polled thought favorably about the ACA. And during the period when Trump tried to eliminate Medicare altogether, as you can see in the early 2000s and in 2016, when there was an attempt to eliminate Obamacare, and you remember John McCain and his famous thumbs up signified that he saved Medicare from being eliminated at that time. But since then, as you can see, there's been a continued improvement in the favorability rating of Obamacare. So it would be politically very difficult at this point to do away with Obamacare, or do away with at least the major parts of it. So the proposals that were considered at the time that the ACA was enacted, I think are worth remembering, because first of all, there had been an attempt to have an individual mandate, that is to say, to require every person in the United States to have health insurance as part of the requirement. That failed to pass Congress. Employer mandate for smaller businesses also failed to pass, and the best that could be done was this, as I mentioned, employers that had 50 or more employees had to have health insurance, but those who had fewer than that didn't require health insurance for their employees. There had been a very considered effort to try to get a public option created, that is to say, a government constructed health insurance program that would have competed with the private industry, but that failed to pass. Short of that was the proposal to have a Medicare buy-in for younger people, which would have been something similar to a public option, but it also would fail to get enough support. And the thing that is most progressive in this area is the single payer system, which what Bernie Sanders is still trying to promote, and which I think has a lot of support among the progressive part of the Democratic Party, and would have, as I'll mention in a moment, major advance would have been to reduce the administrative costs that are now such a big part of what the healthcare industry is experiencing. There also was an effort to negotiate drug prices. And as you may know, in the past, in this current Congress, there has been a bill passed that has allowed the president to expand Medicare coverage, or negotiated drug prices for a limited number of drugs. And over the course of the next few years, more and more drugs will be included in that. But it's still short of a comprehensive plan to negotiate for drugs in general for the Medicare program. And tort reform was also proposed, but didn't make it, eliminating the malpractice lawsuits. So there was still a lot of things that were left on the table. Uh, but despite that, as I mentioned, a lot of the very positive things that have occurred as a result of Obamacare are still very much in place. So some of the remaining challenges that we still have, despite the improvements that have occurred, first of all, we're faced with a continued uh, rising cost, especially for some of the new medications, the biologicals and genetic engineering, which let me just close the door for a second. Um, these new medications are extremely expensive, and that's going to place an additional burden, obviously, on the healthcare system. More focus on prevention. We're still far from having sufficient emphasis on preventing healthcare, particularly in the public health system in general. But I think on preventive strategies that could be included are far less than what are potentially available. Dental, vision, and hearing coverage for adults is virtually non-existent, and is part of the plan for the future if that ever comes to pass. Declining, this is a major issue that I think is only recently becoming into focus, namely a declining physician and nurse workforce, not because fewer people are applying to medical school, far from it. There's still many more applicants to medical school than there are positions. The same for the nursing schools. There isn't a shortage of applicants, but the problem is that early retirement is diminishing the workforce that's actually available to man the system. Excessive administrative burden, as I mentioned, over 25% of healthcare expenditures are estimated to be burned up by administrative costs that have nothing to do with actually improving health benefits. A major new development that is worrying a lot of people is the consolidation that's occurring in the healthcare system with hospital mergers and with now well over 50% of the doctors are employees. I don't know, Peter, whether you would agree with this, but I can recall in our generation that one of the major reasons that people chose medicine as a career was we wanted to be our own boss. This was a huge advantage about having a career in medicine. You didn't have to work for anybody. Well, that is ceasing to be the case now. Well over half of the doctors in the country are employed either by a hospital or by some organization that has acquired their practices.
I'll be back.
And, and this has been, generally the financialization of the healthcare industry is worrying a lot of people about the fact that private equity firms and other for-profit entities are buying up hospitals and physician practices and just extracting as much money as they can out of these systems. And as a result, the major motivation appears to be to make money and not to deliver the kind of services that are traditionally part of the profession of medicine and nursing to try to benefit the society rather than just grease the pockets of the people that own the system. Clinician burnout is another issue that's leading to some early retirement. Was the deprofessionalization and what is called moral injury. That is to say that doctors and nurses find themselves in circumstances where they are unable to fulfill their obligations as professionals, the oath that they've taken to provide services to individuals and to the public are being inhibited by the kind of restrictions that are being placed on the way they have to practice and how quickly they have to see patients, how many patients they have to see in a limited time, and a number of restrictions that are diminishing the joy and the professional satisfaction that comes from doing this kind of work. So I just wanted to end with some thoughts about what Trump's potential anti-ACA initiatives might produce. First of all, I think dismantling the ACA entirely, I think, is not likely. again, as I mentioned, it's politically now a very attractive program, and I think the notion of doing away with it at this juncture is pretty unlikely for that reason. Not to say that there aren't ways in which the ACA's successes could be chipped away. The insurance market regulations could be weakened, reducing efforts to boost enrollment, which has been a major positive aspect of the last several years, where annual enrollment in the health insurance marketplace has increased substantially. Also, they could allow Biden's market reforms to expire, which would increase the premiums and thereby limit the success of the program. Reducing federal funding for Medicaid is another way in which the political winds might blow, particularly reviving the work requirements for Medicaid eligibility. It's now no longer had been the case, but is no longer the case that you have to demonstrate that you're working in order to be eligible for Medicaid. That could be revived, and that would again severely limit the benefit that would accrue from the Medicaid program. And repealing revisions allowing Medicare to negotiate drug prices is another way in which the anti-ACA initiatives could proceed. So these are some of the things to be concerned about. And I think, Trump has said that when he's asked whether he has a better healthcare plan, he says, well, he has a concept of a plan, but so far we've not heard anything substantial about what his actually thinking is about how he might do it. So in any event, here we are, and that's the thank you all very much. And
well, we will. Oh, Jordy, that was a excellent, and I finally understand it now. It's just very interesting. So I think what we'd like to do, Jean, are you still on? Jean?
I am. I'm right here.
Okay. Will you show the people in the class how they can raise their hand on the TV screen on their own computer so they can be recognized?
The different versions of Zoom do it different ways. You might have a hand down at the bottom that says raise hand. Other than that, you might have something called reactions.
Yeah.
And if you click on reactions, you'll have raise hand in there.
Okay.
So those are the two ways on a desktop or a laptop. If you have a tablet, those things might be across the top. And
Okay.
at least some people have seen it. Yep. So it looks like Charlie is the first person with a question. Someone has asked for multiple presenters to share, and that's not what we need for that. That's a different thing, unless someone else has slides. So,
what's your question, Charlie?
The state of Tennessee is one of those that did not adopt Medicaid. On the other hand, the state does have a program called TennCare, which is funded by the federal government with some limitations. Can you talk about that aspect of it? I don't know enough about the details because I don't use the service, but I know it's been a controversial issue here in the state.
Well, TennCare, I think, is essentially a Medicaid program, as I understand it, and it provides the same kind of services that Medicaid does provide. I think the limitations are related to the fact that as far as I know, the federal government doesn't provide the 90% benefit to the state. I may be wrong about that, but I don't think that Tennessee enjoys that financial benefit.
Yeah, I think the state gets a block grant, and then they decide how they're going to divvy it out.
Marv?
Yes. I wanted to comment on the opposition, the level of opposition there was to Medicare and Medicaid at the time. under Johnson administration, even such organizations as the American Medical Association were opposed to Medicare. And I remember what it was like before Medicare. Forget about ACA. Before Medicare, my dad had very serious lifelong illness. And my mom was paying bills long after he passed away because there was no recourse. People were going, she should have declared bankruptcy, actually. I mean, this was a terrible challenge. And I think that people of this generation have no understanding of what this all means and what it was like before we had this kind of protection. And we still fall behind many other advanced countries, particularly in this terms of cost ratio. It's more expensive for our type of healthcare coverage, and yet the results, when you compare them to other advanced societies, are much worse. Anyway, those are my comments.
Well, you're absolutely right, Mark. I think the healthcare costs were the major cause of personal bankruptcy before Medicare and before the ACA. And I think that I don't know what the current statistics are, but it's got to be much, much less than it was. And I think you're right. Before Medicare was enacted, as I mentioned, particularly the older population was thrown into poverty as a result of healthcare costs, and that was the major political argument that Johnson was making about the enactment of Medicare. It wasn't so much to cover healthcare costs, but it was to prevent the poverty that resulted from the expenditures, particularly older people had to make. So. Any other comments?
There's a question from David Slavitt.
Well, not a question. Can you hear me?
Yes.
Yes.
Good. There's a comment I had to make about the intrusion of private equity into hospitals and medical practices, just to observe that it is also going on in exactly the same way with veterinary practices and funeral homes. So that this is the whole area in which private equity sees itself as having a wonderful opportunity, which I think is a terrible threat.
Well, I think the most visited example of it recently, if those of you who are around the Boston area know about Stewart Healthcare, which was a private equity firm that acquired a number of hospitals in the Boston area, extracted all of the money they could possibly squeeze out of those hospitals and forced them into bankruptcy. So the state had to bail out a number of hospitals, and there's still, I think, at least one or two hospitals that ceased to exist as a result of what Stewart Healthcare had done. So that was, I think, a dramatic example of how the profit motive, once it gets to be overwhelmingly dominant in the motivation of these operators of these systems, can just destroy the public benefit that is supposed to accrue from healthcare industry. Bill.
Yeah. Playing off this private equity disaster, don't the states have to approve a transfer of license from, say, a public hospital to a private equity group? And why can't they move in to stop this?
Well, that's not an area that I'm familiar with, Bill. I think you're right, but I'm sure it must vary from state to state. But maybe someone else on the call has more knowledge about this than I do. But I think you're right. I think in general, these kind of transfers of ownership from a public entity to a public entity, to a private equity entity from a public organization does require some kind of an approval. But I'm not familiar with the details of that.
I guess that's what they're working on now in Massachusetts, because the outcry of the horrible greed of Stewart has everyone ready to do something about those laws.
Right.
This is Mike Carey. Can I make a comment?
Please.
I appreciate the enrollment in Medicaid, the number of people covered, but the payments, the reimbursement for doctors in Medicaid is so low that many doctors just can't take Medicaid. I think I read many years ago that the Medicaid would pay $20 for a doctor's appointment, but it costs more than $20 to generate a report from the doctor's secretary. So how do you square this with economic reality of what it costs to run a practice?
I think you're quite right. It's not just Medicaid, but Medicare. Many doctors are opting out of the Medicare program for the same reasons. In fact, there's a huge movement towards concierge medicine, which is in part as a result of the belief or the feeling that doctors have that they're inadequately compensated for the work that they do. So I think the payment systems are clearly in need of reform, and I think you're right. I mean, one could argue whether what doctors are receiving is inadequate or not, depending on your point of view. But I think from the standpoint of what the market is telling us, with the kind of decline in the ability of doctors to maintain practices on their own without having to adopt some kind of an employment relationship to protect themselves economically. These are all factors that I think are moving us in a direction of a more financialized system, which, from my point of view, is very problematic because it eliminates what at least most of us thought medicine was, namely it was a public good that was really designed to try to improve the welfare of our communities, and to substitute the profit motive for that fundamental motivation, I think is over the short as well as the long term, I think a big give up. So you're right about focusing on the inadequacy of physician reimbursement, which is, I think, a major reason why we see such a movement away from private practice into these other organizations and leaving practice altogether.
I just like to add that I'm in New Orleans, and Louisiana has had a charity hospital system since Huey Long. And I think there was about 9 charity hospitals throughout the state, and anyone could go to the hospital in Louisiana and get free medical care. That is changed now, but it was a kind of a unique socialized medicine system for the state of Louisiana. I was at LSU at the medical school, and I thought my job was to take care of people who had low incomes and needed surgery, and I referred them to my hospital that I usually referred them to, where I practiced for my private practice, and the hospital wouldn't admit them because they were Medicaid patients, and they just couldn't get into the hospital. So they went off to Charity Hospital, which was the state hospital that picked up the costs. So it's interesting thing. I'd also like to change the subject just a bit. You say there's a physician shortage, and what has the AAMC done to address that?
I'm sorry, was that a question?
Yeah.
Well,
I understand the residency positions have been limited by the AAMC and Congress in the past.
well, not the AAMC. The Congress has limited the number of residency positions. The AAMC has been very strongly in favor of expanding that support for both, but particularly for residency programs. I think that's a major bottleneck. Now, something like, I think the latest figure I saw was something a little over 25% of the practicing physicians now in the country are foreign medical graduates who have graduated from a non-American medical school, which I think, given the fact that we still have a tremendous number of students who are eager to study medicine but don't have an adequate uh, medical school base, even though it's been expanded significantly in the past few years, there's still fewer physicians being produced by the country than what we need. And I think that's another problem that we need to face. We got a lot to learn from elsewhere that if we took advantage of knowing some of the comparative um, mechanisms that other countries have used to solve some of these problems, I think we'd be much better off.
George, what is the rationale Congress used to limit the number of residents?
The rationale is to save money. One can argue whether this is a government function, and I think that is one of the arguments that the opponents of this program make, is that why should the government be subsidizing rich doctors? That's the way it's usually phrased. And I think, you can adopt that political point of view, but the point is that in the absence of sufficient facilities, sufficient physicians, which the hospitals themselves are not going to fund. The question is whether you're going to put the burden on the individual residents and individual physicians when they're already burdened with enormous medical school debt. That's the counter argument. So my own view is that we, as a society, we would benefit enormously from having a greatly expanded capacity for training students, medical students, to become fully qualified physicians. But until we have that, we have a lot of shortages, particularly maldistribution of physicians in our rural communities and inner city communities. The doctor shortages are even more severely felt there than elsewhere.
Stephen Sure has had his hand up for a while.
Yeah, two things. Addressing the business about doctors that do or do not accept insurance. As with most of us, I have quite a list of specialists whom I see, and gradually, not one of them has ended up accepting Medicare or Medicaid. And that means that in a way, a lot of people would not have access to that quality of care which they can offer. So that's one thing that I would. The other thing is, what sort of protections might there be in place to meet the insanity of some of the things that seem to be on the horizon, like the polio vaccine proposal that was made recently? I mean, it seems like we're returning to some era before the Neanderthal man.
Well, you're quite right, Steve. I think the anti-vaccination sentiment in the country is very worrisome. We know polio is such an obvious example. We've almost entirely eliminated polio from like smallpox, which has been eliminated, but polio right on the verge of being eliminated. And now there's this push to limit vaccinations. It's a death knell for many kids. It's going to be a disaster. So I don't know what to say. It's a politically charged issue having to do with freedom of choice and freedom of speech. That's the rationale, that people ought to be allowed to make a choice for themselves about whether to be vaccinated. Well, it ignores the scientific evidence that unless you have a fully vaccinated population, epidemics are inevitably going to happen. Peter, what is it? You need something like 85% of the population to be vaccinated in order to forestall an epidemic? You're on
Yes,
mute.
you're talking really about herd immunity. I think it's in that ballpark, yes.
Holland's head has his hand raised.
Yeah.
Unmute. Okay, it's Lynn for short.
Okay, thanks.
Yeah, no, I'm curious. Comment on the head of United Healthcare, who was just shot down in the streets a few days ago, and the kind of reason for it was quoted as being a general unhappiness with United Healthcare and the healthcare system. It seems like an awfully extreme reaction. I don't know. Could you comment on that? How do you feel? What all led up to that?
Well, first of all, it occurred within a half a block of where I live. The Hilton Hotel is just right around the corner from our apartment building, so I'm sort of personally aware
So
of it.
you're familiar with it.
I think, you know, and the reaction has been totally bizarre. The fact that there's so many people now are viewing this murderer as some kind of vigilante who has
Oh yeah, horrible.
it's just horrible. But, you know, I think what it expresses is it's a very extreme expression of this frustration that a lot of people have with the insurance industry being complicated, number one, being prone to deny coverage when it seems like a legitimate claim. So there's a lot of problems associated with the administrative aspects, which again I think is a direct consequence of the fact that we've chosen as a country to leave the healthcare system in the hands mostly of the private sector rather than having a universal single payer system and some kind of more comprehensive system for providing the kind of services that are fundamentally needed. But I think we are so far away from that philosophy at this point that I don't see any reasonable prospect for getting back into something more acceptable, certainly within what lifetime we have remaining. We have to go back to.
Well, you mentioned earlier, I think what the 25% of the total budget goes for administrative expenses.
That's correct.
That's huge.
Maria.
Well, I just heard a very interesting NPR program that explained the AI problem with especially this scandalous where they decide whether you have right to be insured in 1.5 seconds, the AI system, without personalizing any of the information. So people that do not have the skills or ways to protest and ask for an exception, that's the major problem, I think, with this United Healthcare system, the AI, that people get so upset about being refused healthcare that they should be insured for.
Well, it's like some of my other things with artificial intelligence. I think there's obviously tremendous advantages that can potentially accrue from the proper application of artificial intelligence to particularly some of the administrative issues that we're talking about. I don't think there's any doubt about the fact that could see some improvement. On the other hand, there's abuses and some ways in which the systems can be made less responsive to the needs than otherwise. So stay tuned.
Gordon, I'd just like to make another comment. Mike Carey here. I'm at LSU at the medical school, and many years ago, Bill Stewart was our chancellor, and he was the head of the public health service.
Right.
We were conversing once, and he said that healthcare will always be rationed, and it's rationed either by non-availability or by inability to pay. And the you talk about the single payer system. I spent a year in England, and of course they do have a single payer system, the National Health Service, and people have to wait months and months and years to get treated. So that's the single, and I was also chief of neurosurgery at the Manhattan VA after Katrina, and there was a lot of waiting for the people to get the operations they needed in the VA system. But I have the highest regard for the VA system, but it is a question of of non-availability of care because so many people need care.
Well, I think in my mind anyway, it's not logical to claim the single payer system for the long wait times. I think the long wait times have to do with the inadequate facilities and systems that are in place to take care of people. It's not that there's a single payer system. That's simply the financial underpinning of the system. It's not the way it's constructed. So I think we can have a payer system and still have an adequate uh, um, enterprise of hospitals and physicians and nurses to deal with the problem. I think you're right. I think in the final analysis, there probably is no end to the amount of healthcare that people would desire, and probably it's an impossible goal to meet. But I think we could do a lot better than we're currently doing, and certainly doing a lot better than what occurs in Great Britain. Arvin.
Yeah.
You'd be surprised about, you're mentioning that the cost of administering healthcare in this country, something in the 25 to 30% league. A substantial, significant part of that cost has to do with claims evaluation and denial. And this is a terrible situation because it's a cause of tremendous consternation on the part of the patients, and it's money thrown away unnecessarily in denying claims.
Right. What the insurance companies call it is the medical loss ratio, which seems to me to be
That's lovely.
a serious way to think about it. They lose money when they pay for medical care.
Yeah.
Peter has his hand up. Peter Brown.
Yes. I was going to say that ask you about the 25% overhead, essentially administrative costs in the Affordable Care Act. Under Medicare itself, the administrative cost is in the single digits.
That's right.
So there's a huge discrepancy between what Medicare has to expend for administration and what the administrative cost is in this system, in the ACA.
Right. An example of the single payer system.
Well, normally when there's a problem, there are alternate ways that people try to fix them. And I'm sort of wondering, I mean, to me, it's always been backwards that we want to, when we're sickest, we want to have the residents take care of us who are the least experienced in handling it. And as we see fewer and fewer doctors, we're seeing more and more nurse practitioners and other ways of treating people, and which sort of is bypassing the traditional medical system. Do you want to comment on that?
Well, it's a very complicated question, Bill, but I think you're basically correct. I think there are a lot of things that traditionally doctors have done, and the AMA has been very defensive about trying to maintain that monopoly, if you will, on certain medical services. I think it's been well demonstrated that a lot of things that doctors do could be done at least as well, if not better, by nurse practitioners or by well-trained non-physician providers. The trick is to figure out where that dividing line is and what kind of supervision is required to maintain the quality. But I think the need to define a spectrum of services that can be provided by a multiplicity of different professionals is certainly one of the ways to get at some of the cost issues that we're faced with. So again, I'd be interested in Peter's view about this, but I'm very sympathetic to the view that nurse practitioners and other highly trained non-physician providers can do a lot of things that traditionally have been done only by doctors.
Hasn't the train really left the station on that?
I'm sorry?
Hasn't the train really left the station on that trend?
Well, I think that, yes, I think the train is going in the right direction, and that's the mean. Yeah.
So AI will help the doctors be more efficient in all the billing and all that sort of thing, they say.
Let's hope.
Right. Again, to even come to a diagnosis, that's sort of a fascinating question, whether AI can help them in the good way.
Well, I think we have reached the witching hour. Is there somebody else that's a comment?
I think this is an important and valuable talk you've given, and you should consider putting it on YouTube or something else where it's available more widely than to your friendly classmates.
It will be on our webpage, which is open to the public.
Yeah.
And
I can make it searchable, Charlie, so that people can find it even if they're not on the web page.
That would be good.
yeah,
Yeah, I can do that.
Jordy, I'm really
A big
impressed.
thank you, Jordy. A big thank you.
Thank you
It's
all.
been fantastic.
Thank you.
I'm impressed how well you did this, having just come back from the Southeast Asia. You're not showing your age.
I think this is extraordinary, and it's
You guys.
of how we should repeat, or we should have more of these kind of valuable expert presentations if we can do it.
Happy holidays to everyone.
You too.
You
And to
too.
you.
Everybody.